Bismillahirrahmanirrahim. Last time in the end of the lecture, I discussed about low motor neuron lesion and its features. Today first about upper motor neuron lesion and its feature. Upper motor neurons, I told you last time, are neurons which are located above the level of lower motor neurons. Located above the level of lower motor neurons in the medulla oblongata, pons, midbrain, and cerebral cortex. Located in the medulla, pons, midbrain, and cerebral cortex. Upper motor neurons control the motor activity through separate pathways. Control the motor activity through separate pathways. And these include corticospinal system and extra-corticospinal system. So upper motor neurons include corticospinal system and extra-corticospinal system. What are the causes of upper motor neuron lesion? These include trauma, injury, vascular cause, maybe hemorrhage, thrombosis. Other cause may be a tumor. Other cause may be a tumor. Now I discuss features of upper motor neuron lesion. I have discussed these features separately for the lesion of the corticospinal system or tract and extra-corticospinal tract. So first features due to lesions of the corticospinal tract. The first feature is loss of voluntary fine-scaled movements of distal parts of limbs. So loss of voluntary fine-scaled movements of distal parts of limbs, say hands, fingers, hands, feet. So distal parts of limbs. The second feature is Babinski's sign is present. So in a lesion due to corticospinal tract, it results into positive Babinski's sign. I would say Babinski's sign is present. Babinski's sign is present. What is Babinski's sign? Babinski's sign is abnormal plantar reflex. Abnormal plantar reflex. What is normal plantar reflex? I'll tell you how do you elicit the normal plantar reflex. You scratch the skin on the lateral border of the sole of foot. You scratch the skin on the lateral border of the sole of the skin of the sole of the foot. There is plantar flexion of all the toes, including the big toe. There is plantar flexion of all the toes. So you scratch the skin on the lateral border of the sole of the foot. There is plantar flexion of all the toes. This is the normal plantar reflex, which is seen in normal individuals. And its root value is S1. So S1 is the root value of the normal plantar reflex. in upper motor neuron lesion, there is Babinski's sign. What is that? Abnormal plantar reflex. So when we scratch the skin on the lateral border of the sole of the foot, there is dorsiflexion of the big toe, dorsiflexion of the big toe, and fanning out of the other toe, fanning out of the other toe. So dorsiflexion of the big toe and fanning out of the other toes. This is the abnormal plantar reflex present in patients of upper motor neuron lesion due to damage to the corticospinal tract. So dorsiflexion of the big toe and fanning out of the other toes. This is the Babinski's sign, that is abnormal plantar reflex. Now, in addition to upper motor neuron lesion, Babinski's sign is also positive in certain other conditions. So positive Babinski's sign in some other conditions, say in infants. In infants, it is positive. Why positive? Because of incomplete myelination of the corticospinal tract. So Babinski's sign is positive or present in infants due to incomplete myelination of corticospinal tract. It is also positive in deep sleep. So during deep sleep, if you elicit the plantar reflex, that will be the Babinski's sign present. Also present in intoxication, nashe mein, say alcohol intoxication, alcohol intoxication, this test is positive. So in addition to upper motor neuron lesions, Babinski's sign is positive in infants, in deep sleep, and during alcohol intoxication. The other feature due to damage to the corticospinal tract is absent superficial abdominal reflex. Absent superficial abdominal reflex. You must have performed the experiment in the laboratory, and you must have tested the superficial abdominal reflex. You scratch or strike the skin of the abdomen, there is contraction of the abdominal muscle. This is the superficial abdominal reflex. It becomes absent. Why absent? Due to loss of tonic excitatory impulses along the corticospinal tract to the interneurons in the reflex arc of this reflex. So due to loss of tonic excitatory impulses along the corticospinal tract, which go to the interneurons in the reflex arc of this reflex. Next feature is absent cremasteric reflex. Absent cremasteric reflex. When we scratch the skin on medial side of the thigh, we scratch skin on medial side of the thigh, there is retraction of the testicle. There is retraction of the testicle on that side. So we scratch the medial side of the thigh, there is retraction of the testicle on that side. This is the cremasteric reflex. Its root value is L1. So L1 is its segment or root level. This reflex is also absent in lesion due to corticospinal tract damage. Again, the cause is loss of tonic excitatory impulses. Loss of tonic excitatory impulses along the corticospinal tract to the interneurons in the reflex arc. So loss of tonic excitatory impulses along the corticospinal tract to the interneurons in the reflex arc. So these are the features due to lesion in the corticospinal tract. I repeat, loss of voluntary skilled movements of distal parts of limbs. Babinski's sign is positive, is present, and loss of superficial abdominal reflex, and also loss of cremasteric reflex. So these are the features due to lesion in the corticospinal tract. Now, features due to lesion in the extracorticospinal tract. Features due to lesion in the extracorticospinal tract. Large number of muscles are affected. Large number of muscles are affected. Say, there may be hemiplegia. One side of the body is paralyzed. Hemiplegia. There is spastic paralysis. Spastic paralysis. Loss of movements along with hypertonia. So loss of movements along with hypertonia, there is spastic paralysis. Of course, muscle tone is increased, right? There is ankle and knee clonus. Ankle or knee clonus. When muscle is subjected to sudden maintained stretch, these rhythmic, regular movements, contractions, which is called clonus. So there is knee clonus or there may be ankle clonus in these cases. Tendon jerks become brisk, hyperactive, exaggerated. So exaggerated, brisk or hyperactive tendon jerks. Generally, in these patients, arms are flexed and legs are extended. Arms are flexed and legs are extended. Right? So I mentioned that tendon jerks become exaggerated, brisk or hyperactive. Say you test knee jerk, ankle jerk, bicep jerk, tricep jerk. These become brisk, hyperactive or exaggerated. There is clasp knife rigidity. Clasp knife rigidity. So clasp knife rigidity in these patients are in a patient, the doctor tries to flex the arm at elbow, tries to flex the arm at elbow. There is initial resistance to flexion. But when doctor go on flexing the arm, after some initial resistance, the arm is abruptly flexed. This is the clasp knife rigidity feature of the upper motor neuron lesion due damage to the extracorticospinal tract. It's clasp knife rigidity. There is only slight muscle atrophy. Not much. So slight muscle atrophy is due to disuse of muscle. So slight muscle atrophy due to disuse of the muscles. So these are the features due to lesion involving the extracortical involving the extracorticospinal tract. Now keep in mind, in the clinical practice, these tracts, corticospinal, extracorticospinal, are not generally damaged generally at the same time. Maybe damaged separately or maybe damaged combined. So you will combine these features, and these features will be the features of the upper motor neuron region. I sum up: loss of voluntary fine skilled movements of the distal parts of limbs. Babinski's sign is positive. Loss of superficial abdominal reflex, loss of cremasteric reflex, large number of muscles are affected, say hemiplegia. There is spastic paralysis, loss of voluntary movements with increased muscle tone, ankle and knee clonus, tendon jerks become brisk, exaggerated, and there is clasp knife rigidity. These are the features of the upper motor neuron region. I have discussed these features separately for corticospinal and then extracorticospinal tracts, and then all are the features of the upper motor neuron region. Next, about the types of paralysis. Types of paralysis. I will tell you about the types of paralysis. Monoplegia. Paralysis of one limb. So one limb is paralyzed, say one arm, one leg. This is monoplegia. Diplegia. Diplegia, when two limbs are paralyzed, which are corresponding limbs, when two limbs are paralyzed, which are corresponding, say two arms are paralyzed, two legs are paralyzed. Now when two legs are paralyzed, it is called paraplegia. Paraplegia, when two legs are paralyzed. Paraplegia, when two legs are paralyzed. Then quadriplegia. Quadriplegia, when all the four limbs are paralyzed. So when all the four limbs are paralyzed, it is quadriplegia, right? So this was about the types of paralysis. Now I discuss about lesions of the spinal cord. Lesions of the spinal cord. First, about the lesion of the dorsal nerve root. Lesion of the dorsal nerve root. You know, dorsal nerve root is sensory. Right? Keep in mind, when only one dorsal nerve root is damaged, there is no sensory loss. So no sensory loss when only one dorsal or posterior nerve root is damaged, because of the overlapping of the adjacent dermatomes. Because of the overlapping of the adjacent adjacent dermatomes. To produce sensory loss, at least 3 dorsal nerve roots must be damaged. So in order to have sensory loss, 3 dorsal nerve roots must be damaged. With the damage of one dorsal nerve root, there is no sensory loss because of the overlapping of the adjacent dermatomes. In dorsal nerve root lesion, there is a loss of muscle tone in the affected part, loss of muscle tone, loss of superficial and deep reflexes, loss of superficial and deep reflexes in the affected part, Movement of the affected part is not possible. Movement of the affected part is not possible. Why? Because of loss of impulses from proprioceptors to the brain. So movement of the affected part is not possible. It is not normal movement, not possible when due to loss of impulses from proprioceptors to the brain. Right? So these are the features of when there is lesion in the dorsal nerve root. So what are the features when there is lesion in the ventral nerve root? Lesion in the ventral nerve root. You know, in the ventral nerve root, there are somatic motor nerve fibers. Somatic motor nerve fibers. And also, in the segment T1 to L2, there are autonomic fibers which are from segment T1 to L2. The fibers are autonomic, and these are sympathetic nerve fibers. Due to damage to the somatic motor fibers, there is flaccid paralysis. So flaccid paralysis due to damage to the somatic motor nerve fibers in the ventral root. Loss of superficial and deep reflexes. Loss of superficial and deep reflexes in the affected part. Loss of muscle tone in the affected part. Loss of muscle tone in the affected part. So when ventral root in the segment T1 to L2 are damaged, then due to loss of sympathetic nerve fibers, there will be vasodilatation in the affected part, fall in the blood pressure, loss of sweating, skin become dry, and there is the skin flushing because of vasodilatation. Right? So when the damage to the autonomic nerve fibers, there will be loss of vasomotor tone, vasodilatation, fall in the blood pressure, flushing of skin in the affected part, skin become dry in the affected part due to loss of sweating. So these are the features due to damage to the ventral nerve root of the spinal nerve. Now we come to the sections of the spinal cord. First about the hemisection of the spinal cord. Hemisection of the spinal cord. Spinal cord is damaged half. So it is hemisection of spinal cord. What is the cause of this hemisection? Fracture dislocation of the vertebral column. Fracture dislocation of the vertebral column due to bullet wound, bullet wound, stab wound, or a spreading tumor. So bullet wound, stab wound, or spreading tumor, they will be spinal cord hemisection. Spinal cord hemisection. After spinal cord hemisection, there is first stage of flaccidity. After hemisection, there is stage of flaccidity or spinal shock, which remains for about 2 to 3 weeks. Which remains for 2 to 3 weeks. After the stage of spinal shock, then a stage of reflex activity, right? And after this, there will be features at the level of the hemisection, below the level of hemisection, and above the level of hemisection. So features at the level of hemisection, below the level of hemisection, and above the level of hemisection. So what are the features at the level of hemisection? There is lower motor neuron type of paralysis ipsilaterally at the level of hemisection. So lower motor neuron type of paralysis at the level of hemisection ipsilateral on the same side. So on the same side, there is lower motor neuron type of paralysis. Say flaccid paralysis, loss of muscle tone, muscle atrophy, right? Fasciculations, right? So these are features due to lower motor neuron type of paralysis or lesion. On the contralateral side, no motor loss. So at the level of hemisection, on the contralateral side, no motor loss on the contralateral side at the level of hemisection. We will come to sensory loss. Now at the level of hemisection, there is complete anesthesia. So complete anesthesia. Loss of all sensations. Loss of all sensations at the level of hemisection. Complete anesthesia at the level of hemisection due to damage to the dorsal nerve root, damage to the dorsal nerve roots or dorsal horn and dorsal horn. I mentioned about the features of low motor neuron type paralysis at the level of hemisection. These features are damage to the alpha motor neurons. So this motor paralysis, motor loss is due to damage to the alpha motor neurons, which are low motor neurons. Right? So at the level of hemisection, there are features of the lower motor neurons paralysis ipsilaterally. On the contralateral side, no motor loss. We got the sensory loss at the level of hemisection. There are features. There is complete anesthesia. Loss of all sensations ipsilaterally, loss of all sensations or complete anesthesia at the level of hemisection. On the contralateral side, no sensory loss. So no sensory loss contralaterally at the level of hemisection. Now we come to the features below the level of hemisection. Features below the level of hemisection. There are features due to upper motor neuron type of paralysis below the level of hemisection ipsilateral. So ipsilaterally, there are features of upper motor neuron type of paralysis below the level of hemisection. So don't forget, ipsilaterally below the hemisection, there are features due to upper motor neuron type of paralysis. On the contralateral side, no motor loss. On the contralateral side, no motor loss. Right? So don't forget, below the level hemisection, there are features of upper motor neuron type of paralysis ipsilaterally, and contralaterally, no motor loss. Now about the sensory loss. Below the level of hemisection, ipsilaterally, there is loss of sensation carried by dorsal column medial lemniscal system. Dorsal column medial lemniscal system. So ipsilaterally below the hemisection, so you have loss of sensation carried by dorsal column medial lemniscal system. Fine touch, tactile discrimination, proprioception, vibration. So these are lost ipsilaterally below the level of hemisection because of damage to the dorsal column medial lemniscal system. So because of damage to the dorsal column medial lemniscal system. I mentioned that below the level hemisection, ipsilaterally, there are features due to upper motor neuron type of paralysis. Why? Because of damage to the corticospinal and extracorticospinal tract. So damage to the corticospinal and extracorticospinal tracts, it gives features of the upper motor neuron type of paralysis. Now contralaterally, sensations carried by the spinothalamic tract are damaged. 1 to 2 segments below the level of hemisection. So on the contralateral side, the sensory loss is sensations carried by the spinothalamic tract, but this loss will be 1 to 2 segments below the level of hemisection. Why? Because of oblique crossing over of fibers of spinothalamic tract. Because of oblique crossing over of fibers of the corticospinal tract. So contralaterally, the sensory loss will be loss of sensations carried by the spinothalamic tract. And this sensory loss will be 1 to 2 segments below the level of hemisection because of the oblique crossing over of the fibers of the spinothalamic tract to the opposite side. So this was about the sensory loss below the level of hemisection. Ipsilaterally, sensations are lost which are carried by the dorsal column medial lemniscal system. On the contralateral side, sensations are lost which are carried by the spinothalamic tract. Now if the hemisection spinal cord is in the segment T1 to L2, if spinal cord hemisection is in the segments T1 to L2, then there will be loss of vasomotor tone, vasodilatation, fall in the blood pressure. It may occur when there is the hemisection is in the segment T1 to L2, there is vasodilatation and fall in the blood pressure. Now when we analyze the features below the level of hemisection, on the ipsilateral side, there is motor loss. There is motor loss. And what is sensory loss? Sensory loss ipsilaterally below the hemisection is the sensation carried by the dorsal column medial lemniscal system. What about the opposite side? On the opposite side, there is no motor loss. no motor loss. And what is the sensory loss on the opposite side? Sensory loss is loss of sensation carried by the spinothalamic tract. Say crude touch, tickle, itch, pain and temperature. Pain and temperature. So if you analyze the two sides below the level of hemisection regarding the motor loss, sensory loss, you say that ipsilaterally motor loss is predominant and contralaterally sensory loss is predominant. You understand? Ipsilaterally motor loss is predominant because there are features due to upper motor neuron type of paralysis. And you got sensory loss on the ipsilateral side. Sensory loss is for tactile discrimination, proprioception, vibration, which are not important for the patient. So sensory loss is not important for the patient who is paralyzed ipsilaterally. What about contralaterally? Contralaterally, there is loss of crude touch, tickle, itch, pain and temperature. Pain and temperature. So sensory loss is predominant, is important. On the contralateral side, loss of pain, temperature, touch, tickle, itch, etc. So this predominant motor loss, ipsilateral, and predominant sensory loss, contralaterally, is important. And this is also called as Brown-Sequard syndrome. Brown-Sequard syndrome. It's Brown-Sequard syndrome. So keep in mind that ipsilaterally, in these patients of hemisection, motor loss is predominant or important. Contralaterally, sensory loss is predominant or important in these patients, and these features are called as Brown-Sequard syndrome. So Brown-Sequard syndrome is also spinal cord hemisection. But just we consider that ipsilaterally motor loss is predominant and important, while contralaterally sensory loss is predominant or important, and these features are called as Brown-Sequard syndrome. So this was about the spinal cord hemisection. So we'll discuss other sections next time.